So welcome everyone to our semantic standard training. I'm actually very happy that we have today Kristin Gnodtke, who is our clinical data specialist of the Personalized Health Informatics group, who will introduce you to the different standards which we are using in SPHN. Please be aware, I think you could talk for days about each of these standards. So actually Kristin really had to drill it down for each standard to the most essential parts to give you an idea of in this introductory session on these standards. But of course, if you really start using these standards, I think you really can also engage with us in a discussion about how to use these standards best. And also we are planning to do more in-depth sessions on some of these standards in the future. With that, I would like to give the floor to Kristin. Looking forward to learn more about all the standards.
Thank you, Sabine, for the nice introduction, and welcome to everyone to this semantic standards training, and thank you for your interest in this topic. So we will have poll questions, and whenever this red question mark appears, that's also a reminder for myself, a question will come up on your screen and you will have the chance to answer that one. So what will we cover today? I will talk about semantic standards in general, what is it? And then immediately dive into the standards we are using, ATC, CHOP, ICD, SNOMED CT, and LOINC. And 45 minutes are short, so let's start. Why do we talk about semantic standards? So when you have, or when you deal with clinical data come that someone is asking for systolic blood pressure in the English world or in the research world where English is the language, but you can also have it in other languages as a term or as an abbreviation like SAP, which stands for systolic arterial pressure, or in German, or now we have SBP. What is it out of context? Is it the Swiss biobanking platform? Probably not, because you see all the other terms and it's systolic blood pressure. So now, as I said, context for a human being, you can probably understand what is meant and you can translate with a translating platform. But we are dealing with interoperability with data, and we want machines to understand the meaning of the term. And that's why we want to use semantic standards. This is now a picture of systolic blood pressure from SNOMED CT. And you see below very small an ID, a number of this term. And this is very handy for machines to interact with each other and understand the meaning when data comes from different systems. So what types of semantic standards are there? The easiest one, or the most simple one, is controlled vocabulary. Like a glossary, you have terms like viral pneumonia and bacterial pneumonia, but they are defined maybe with a definition, but they are not linked to each other. You don't know in which relationship they are. A controlled vocabulary can also be a classification or monohierarchy if you add a relationship, a hierarchical one. So-called is a relationship, a viral pneumonia is a pneumonia. Then we have semantic standards, which are a polyhierarchy. What does it mean? A term like bacterial pneumonia can have more than two parents. Here, for example, bacterial respiratory infection. And the most advanced ones are ontologies or ontology-like semantic standards. And when do we speak about an ontology? It's when, in addition, you have relationships sidewards, so-called attribute relationships. For example, here that a bacterial respiratory infection has a finding site of respiratory system. And this is a link to parallel hierarchies, as you can see here, for example. So far about types of semantic standards. And here you can see an overview. about standards we use in SPHN. I cannot speak about every single one today, but as mentioned, we made a selection, and let's start with ATC. On top of each intro slide for each classification, you will see some gray, some statements in gray. That's more the administrative information. I will not go into that, but you will have it when we share the slides after the training for completeness and for your information. So ATC, what is it? It's a classification for medications in a specific context, as you will see later in an example of an indication of this medication or substance. In this classification, we have 5 levels, as you can see here. And where is it used? ATC in Switzerland is used, for example, by Swissmedic. Swissmedic, on their website, they publish the list of all the medicinal products that are approved to be used in Switzerland. And in general, ATC is targeted to the active substances. Now, how does it look like? Oh, first a question mark. So now we will ask you the first question. Don't be afraid if Paul comes up. Don't be afraid to answer it. It's anonymous. Since when does ATC exist? Guess 1976, 1981, 1995. Thank you for answering. It's great that you participate, and we are waiting for some more answers. And Sabine will end the poll in a second. And yeah, I see now most of you said 1995. Actually, the right answer is since 1976. So really a lot of years of ATC. I also did not imagine that until I looked it up. Now, let's continue with one example. For example, the substance of clopidogrel. How does the code look like in ATC for this substance? It is B01AC04. So a code looks more or less like this in ATC. And what does it mean? B, for example, it stands for that this substance is in the hierarchy of ATC in the category of blood and blood-forming organs. And then with each part of this code, you can get more information. So it's an antithrombotic agent. On level 3, we have the same information. It is a platelet aggregation inhibitor. And 04 then really specifies which substance. So just to illustrate to you how the code works in ATC. Now, classifications, monohierarchies have some limitations, and I would like to make an example for that at the ATC classification. Let's have a look at the active substance of acetylsalicylicum. Maybe most of you, I guess, know what it is. And I was looking in the Swissmedic Excel file from the website. Can I find it there? And what do I find? And I find one code for the indication of thrombocytic aggregation inhibitors. So it's approved in Switzerland for this indication with the ATC code of B01AC30. But I also find it, oh, and here you see just for the completeness what it means in the hierarchy of ATC. And I find it as well for another indication, the relief of fever and pain during colds. You probably all took it for that reason. And here we have another ATC code to identify exactly the same substance. And the reason for that is that we have a hierarchy in ATC that is according to indication. So the first one is targeted on the blood and blood-forming organs, and the other indication is targeted to the nervous system. So keep that in mind when we later come to polyhierarchies. Some other limitations of ATC are that not all the 5 level codes that are used for really identifying a substance are identifying single substances. You also have codes for combinations, and you have codes that are for broader terms, not really one single substance, but a group of substances. Another thing is that ATC does not include all the medications you might want to look at while doing research. So investigational medicinal products, so-called IMPs, for example, are not yet in ATC as long as they are under investigation, but you can find them in the National Cancer Institute thesaurus, for example, with also a unique identifier, as you can see here. Then you have diseases where you have more custom mixture substances, like in oncology, and there are not always the codes for those mixtures in there. Some more information you can find under these links about ATC, and the links, we will share the slides, so the links will be available to you. Now let's go straight to the next one, which is CHOP, the Swiss classification for procedures. And it's covering surgical procedures, but also more than that. From the German name that you can see here, you might imagine, oh, it's just about surgery, but it's not. Also radiotherapeutic therapeutic procedures, procedures for patient activation, some administrative procedures. It's really a lot. And it's also a monohierarchy like ATC. It has 6 levels of hierarchies, and it is mainly used for billing and accounting. So really the hospitals use it yeah, for that reason, and do the coding on a routine basis for that. The CHOP classification is really used only in Switzerland and is based on ICD-9. Germany, Austria, for example, have other coding systems for that. Just an example how the hierarchy looks like. As I mentioned, 6 levels of information, and important to remember when you prepare data or when you receive data for your research project, what you will find is only the most granular code. So in the coding handbook or guidelines, it's clearly stated that coders should only code the most specific procedure, and you will find 6 level codes for CHOP. Now, ready for the next question. It is coming up at the moment on your screen, and I read out the question for you. How many CHOP codes are there? What do you think? Just guess. And I was looking at the CHOP version of 2020. And I mentioned, yeah, it's a lot. And I can see from your answers, you also think it's a lot of CHOP codes that are available. And you can imagine if there are so many, as a coder, you need to be well trained to really choose appropriate codes. And I think we have a picture, and here you can see the results. So your answer, most of you are right. It's more than 15,000 CHOP codes in the system. Now that's all about CHOP. Now let's move on to ICD-10, which is, yeah, I think the most well-known one in Switzerland. It's for diagnosis classification, and it is also used with the Swiss DRGs for accounting. It's also used for statistics and reporting. And it is based on the ICD-10 of the WHO. So each country makes its own modifications. In Switzerland, we use the German modification as the basis for all the language versions in German, French, and Italian. So GM stands for German modification. Other countries have their own modification. Now, how does it look like? Here, for example, we have a code Q89.00, which stands for congenital splenomegaly. And this would be the most granular code used for coding. And just to show to you, where does this code stand in the hierarchy of the classification? So we have a 4-digit, 3-digit code, a group, and the top level would be the single chapters. And each diagnosis is in the classification only once under a specific chapter. So as mentioned before, only the most granular level is used for coding the diagnosis data, but not all groups have a 4-digit category. So there can be only 3, 4, or 5. So it really depends where you are. So if you're validating before you ingest such data, you can well have 3-digit codes, and it's a valid code for classification. Now, here some further information, links for you, where you can find more information about ICD-10 and WHO. And here, the next question comes about ICD-10. And the question is, which of the statements about ICD-10 GM and ICD-10 CM are correct? So which of the statements is correct? Is it a statement about ICD-GM and ICD-10 are is GM only used in Switzerland? Is CM another one term for GM, or is CM the modification for the US? These are the 3 answer options, and I see the answers coming in. Thank you for answering. And don't be afraid, your name is not coming up, just to mention that again. So let's see what's the result. So most of you think ICD-10 CM is the modification for the S, and this is true. This is correct. So next, coming to SNOMED CT. It is a polyhierarchy with attribute relationships. So an ontology-like classification, and it's very broad. It covers, or it aims really to cover, the whole electronic health record, everything what you can find in a hospital to encode data should be in. And it is Switzerland has a license, and the National Release Center for Switzerland is eHealth Swiss. So when you use it, please get a license from eHealth Swiss. It's free. It doesn't cost anything. And it is, for example, planned to be used for the electronic patient dossier. And I have also heard about single research projects or clinical trials where it's planned to be used. And here, just as an impression, we have in this polyhierarchy single hierarchies that are connected to each other. And here's the top level list of hierarchies. And we have, for example, body structure, event, we have social context, we have specimen, we have organism. And I would like to go a bit deeper now into what is a polyhierarchy, how does it look like in SNOMED CT, and what is, for example, such an attribute relationship. Polyhierarchy here, this is just tree, as mentioned before. In a polyhierarchy, a term like bacterial pneumonia can have more than one parent. And let's make an example. We would like to ask, imagine you have data in SNOMED CT, we would like to ask for all patients with a disorder of respiratory system. Not all the data might be encoded with this specific SNOMED code, but could also be encoded as a pneumonia or as a viral pneumonia. Or another researcher looking at bacteria might ask, give me all the patients with bacterial infectious diseases. And the beauty of the polyhierarchy is you can ask from different perspectives and still get the data. For example, here in this example, bacterial pneumonia included in both answer sets, depending on where you come from, it's going to be in. And this is, as you might have seen before from the monohierarchy, is not that easy. So it allows to aggregate data according to different characteristics. Now about attribute relationships. Here I brought for you a screenshot from the SNOMED CT browser. In the browser, you can not only see the relationships between the concepts, but also their definition. And the definition is illustrated in such a tree. And the yellow ones here, the yellow boxes, are the attribute relationships. For example, viral pneumonia has a pathological process, which is an infectious process. And this is part of the definition, in addition to the hierarchical relationships, like that viral pneumonia is a child of an infective pneumonia, here depicted in the lilac boxes. Now, the feature of those attribute relationships enables to uncover hidden information that's hidden in the data. What does it mean? I would like to search now in my data, SNOMED CT annotated data for all patients with lung problems. In a clinic, a doctor, no doctor would have encoded it as a patient with lung problems. It would be a patient maybe with bacterial pneumonia or with viral pneumonia or just pneumonia if the reason was not clear. And how can I now get still the information even if I'm not asking for viral pneumonia? I have this attribute relationship of the finding site, which directs me or gives me the information that this condition was in the lung. And with that, all the patients which were encoded with viral pneumonia are included in the results or in my answer set. So this is the advantage of polyhierarchies with, in addition, attribute relationships when we use that, and have certain advantages for data retrieval or information retrieval. Here are some further information about SNOMED CT. Maybe to mention, they really have a very good e-learning tool, free even if you don't have a license, to register here and watch several videos. And some of my examples are taken from those. There are also paid courses, and it's really a good source for further information. Now, ready for the next question as we are at the end of SNOMED CT. Just of curiosity of the DCC and the free group, how often do you use the SNOMED CT browser in your daily life? Is it more than once a week, every 2 weeks, once a month, or actually not yet or never? So really curious what the answers will be. Make your choice from your experience, from your work life. And in a second, we will see the answers. Just waiting for a couple of more answers. Just your name will not pop up, just answer. We can see most of you actually never used it. Okay, that's interesting. So hope you're still interested. Let's continue to look at both SNOMED CT versus ICD-10 polyhierarchy versus monohierarchy. I brought an example for you. We have patients with a parainfluenza virus pneumonia. And I looked, okay, how is that coded in ICD-10? And we have a code of J12.2. And how is it coded in SNOMED CT? And you can see the code on the left side. Okay, this is our basis. We have patients and it's encoded with those two codes, with the ICD-10 code and with the SNOMED code. Now, as a researcher, I want to ask questions to my data. And the first question is, does the patient have respiratory disorder? Does the patient have an infection? Does the disorder affect the lung? And is the disorder caused by a virus? Now, we would like to ask you with our poll, what do you think, how many of those questions are answerable by ICD-10 and by SNOMED CT? So which of those questions, or how many, 1, 2, 3, or all 4, can be answered by both of the classifications? Make your choice. Do you think, well, all 4 questions can be answered by both the classification of ICD-10 and SNOMED CT? Or is it maybe just 3 or just 2? And I will show in a second the answers and explain why. And just coming in the answers. It's fairly even. So yeah, most of you thought, okay, 2. That's the most that was guessed. So let's see. The first question, does the patient have respiratory disorder? It is answerable by both. Why? In SNOMED CT, because parainfluenza virus pneumonia is a subtype of respiratory disorder in the SNOMED CT hierarchy. It is answerable by ICD-10 because the parainfluenza virus pneumonia code is in the chapter of respiratory diseases. And from the hierarchy going up, we can retrieve that it is a respiratory disorder. Second question, does the patient have an infection? Yes, it can be answered by SNOMED CT because it's also a subtype or a descendant of infectious disease. In ICD-10, I cannot really answer that question because the code is not in the chapter A of certain infectious and parasitic diseases. As mentioned before, in a monohierarchy, I have to decide where to put it, and I have it just under one point of view, or as an ATC you have seen, then we have duplications and have the substance twice. Now the next one, does the disorder affect the lung? Yes, by SNOMED CT, no by ICD-10. In ICD-10, the information is not available. In SNOMED CT, actually, the attribute relationship kicks in and allows us to answer that by defining site is lung structure. And is the disorder caused by a virus? In ICD-10, no information available. In SNOMED CT, yes, again, the attribute relationship is allowing us to answer that. Thank you very much for taking part into that poll for that question. That was important to show, I think. And as I don't know, time is short, let's move on quickly to LOINC, which is the last one we covered today. LOINC is an identifier for lab tests, or it's well known for that, but it also covers clinical observations and documents. It has, from its structure, 6 axes, a so-called axial hierarchy, and in relation to other standards, in LOINC, there are example units in UCUM. UCUM is a standard convention for units of measure. 6-axis, here you can see the 6-axis. It's component, property, time, system, scale, method. What is it exactly? Let's make an example. We have a LOINC code here of 2340-8. -8 is a so-called check digit, but each LOINC code has 3 till 7, maximum 7 characters long at the moment. It might be extended in the future as LOINC is still growing. And what does it mean? It's glucose mass per volume in blood by automated test strip. Now, each of the 6 axes gives a piece of information into that LOINC code. The component or analyte is glucose. The property refers to what is later then reflected in the unit. It's MCNC stands for mass concentration. So this is the way how it is measured. Timing, here PT stands for point in time. It can also be a period of time. System is blood, BLD stands for blood. What kind of measurement? It's a quantitative measurement. So we can expect a number here. Can also be qualitative for other tests like positive or negative. And we have a method specified, which is a test strip automated method. This is the information. This is reflected by this specific LOINC code. Now, LOINC codes belong to a class or a type, for example. Here, this LOINC belongs to the class of chemistry and is of type laboratory, as I mentioned, not only codes for laboratory, but also for clinical observations like blood pressure, for example, or others. Well, what else? Those 6 axes are kind of independent hierarchies, and you can see them also as kind of attribute relationships. And they allow us, when we want, for example, for our research project to say, okay, I want those LOINC codes for glucose, but do I really want this specific one, only this specific test? Probably not. More often, it might be the case that you want all glucose measurements in blood. That's enough. So you take just 2 of the 6 axes and say, okay, the component should be glucose and the system should be blood, or something in between, all patients with glucose in blood with a quantitative test. So here you can really, because we have the 6 independent axes, you can really tailor your question. And in the LOINC browser, you need to register to get access to the LOINC browser, but it's for free. The whole system is for free. There is a certain syntax you can use to make those searches. And for the last one, the search string would look like this. Glucose is the component, and system BLD, and scale QN. And that brings us to the next poll question, which should come up in a second on your screen. What is the correct search string to ask for all LOINC codes for bilirubin in blood measured in milligram per deciliter? And there are 3 choices. And have a look at the syntax, maybe. You can still see the screen. And remember, yeah, what do you think is the right one? Make your choice. Answers are coming in. Only 20. I guess there are more people online, so we are waiting a little bit longer. What do you think is the right search string to get this result in the browser, or if you have LOINC in another system or in RDF, for example, you can also ask those questions, or in other systems. And here you can see the result. Most of you voted for the last one, which is correct. That's the right search string. Now, I hope we have a little bit more time. Let me check the time. Yeah, that's good. To look at LOINC parts. So we have the 6 axes, and each value in this axis is a so-called part. And here I would like to compare 2 LOINC codes. From the numbers, like the LOINC code, they look very different. One starting with 3, the other one with 7. So it does not tell anything, because these are just random numbers that are assigned. And for the first one, that means hemoglobin mass per volume in arterial blood. For the second one, it's hemoglobin mole per volume in arterial blood. So I highlighted the difference in the long common name in red. Now let's have a look at the single axis component first. Both have as an analyte the thing what's measured is hemoglobin. Property for the first one, mass concentration. The second one, it's actually substance concentration. That's why in the square brackets, the difference here. Timing, both is a measurement. At point in time, we are looking at arterial blood, scale is quantitative, and both codes, this is well accepted, don't specify the method. So not all the LOINC codes specify the method. Okay, so the difference is actually only in one single axis, and it means we have, or we end up with 2 different LOINC codes. Now you can see, okay, maybe I'm really interested in all the hemoglobin in arterial blood tests, and they are comparable. You know, the way of how it's measured for your research question, this might be, depending of course of your research question, might be a comparable thing, and you might need to include both in your set you want to look at. And please keep in mind, important to know, a change in one single part can make a different LOINC code. Okay, so far about the LOINC codes. Now I mentioned the units. The units are not part of the definition of a LOINC code, but the Regenstrief Institute, which is hosting LOINC, provides example units, and as they recommend EUCOM as a standard convention for units, we have here for the first one gram per deciliter, and for the other one millimole per liter as an example, and you can find that information also in the LOINC browser for each LOINC code for lab. Yeah, I mentioned the browser, and there's more information, a user guide, and really there is much more to say about LOINC, but we have not enough time to go into each and every detail. Maybe we can do that in further sessions. So that was it about the single standards. And let me make a little bit of a summary here, or a new picture looking at different semantic standards. So what we can say about our SPHN semantic strategy, and it's not just the SPHN semantic strategy, also when you look into other countries, it's well recognized meanwhile that we cannot live or focus on one single standard. We need to look at several standards. They have strengths and weaknesses, and they have different areas where they are applied. And so it's natural that those standard development organizations need to talk to each other. And there are initiatives, agreements, recommendations, and also mapping between standards available. And here you can just see a couple of them. That's not a full picture, of course, and there's also things that come with some European initiatives, for example, that further mappings are developed, and especially with the upcoming of ICD, 11 in the future, it will probably be a new discussion or a further discussion how, for example, SNOMED CT and ICD-11, if there is a possibility to map between them, for example, and mapping is definitely an interesting topic when we really want to use the standards. So let me summarize. Semantic standards are important to support interoperability, to understand each other as individuals in the community, but most important, they provide identifiers, and that's crucial, that machines can understand each other, different software systems, and not one single standard is of key, but we need a harmonized ecosystem and also look at possibilities of mapping. And in our strategy in SPHN, we have national and international standards we are looking at, or we need to take into account the national ones, especially because we have routine data available in those standards already, like CHOP and ICD-10. And semantic standards are independent of technical platforms. So you can use them in relational databases and graph databases. Wherever you need to really fix the meaning, they are for fixing the meaning. And here we provide some more links related to SPHN and where we use the standards. So we use them in the SPHN dataset. Here linked to the SPHN strategy of SPHN, and also a documentation on read the docs on the semantic standards, the dataset and the implementation and RDF. And with that, I'm in time, and thank you very much for your attention. Thank you very much for answering the poll questions. And I think we are ready for questions and answers, and happy to answer your questions.